the approximate risk of getting disease in siblings is about 10%. Age, the risk increase with increasing age. The primary open-angle glaucoma is more commonly in elderly after 40. High myopia, diabetes mellitus are also risk factors of primary open-angle glaucoma. Incidence of this type of glaucoma varies in different populations. In general, it affects about 1 in 200 of population above the age of 40 years. What are the clinical features of primary open-angle glaucoma? Unfortunately, primary open-angle glaucoma is a silent process. Usually, there are no symptoms in early stage. Only about 15% of patients have such symptoms as mild headache and occasional colored halos due to transient corneal epithelial edema. But 85% has no complaints in early stage. As I said before, the early diagnosis is the best way for preventing the severe damage, but it's very difficult to diagnose the glaucoma in early stage because patient has no complaints. Gradual loss of peripheral vision occurs. Loss of central vision is usually the last to occur. Ocular examination, including slit lamp biomicroscopy, may reveal dystrophic changes of the anterior segment, iris. Gonioscopy reveals open angle of the anterior chamber. So no constriction, no restriction, no obstruction of the angle of the anterior chamber. Angle is normal, but the trabecular meshwork has problems. The main symptom is raised intraocular pressure, but not in all the patients, as we also discussed half an hour ago. In the initial stage, the intraocular pressure may not be raised permanently, but there is an exaggeration of the normal diurnal variations, more than 5 millimeters of mercury. So we should examine IOP 2 times a day during several days. If you suggest that this is glaucoma, but the patient during the examination has normal intraocular pressure in your office hours, try to ask the patient to come in different hours next days. For example, today the patient came to you at 9 a.m. Ask him to come tomorrow at 11 or 12. The next day at 4 p.m. and maybe you'll find the spikes of intraocular pressure in the evening, and you'll find, and you'll prove your suggestion that the patient has glaucoma. Glaucomatous changes in the optic disc may be seen in patients with open-angle glaucoma. They are typically progressive, asymmetric, and present a variety of characteristic clinical pattern. Visual field defects usually run parallel to the changes at the optic nerve disc, as we have already discussed, and thus will continue to progress if intraocular pressure is not controlled. It's also clear. So diagnosis. Established primary open-angle glaucoma is labeled when raised intraocular pressure is associated with, and sometimes normal intraocular pressure, associated with definite glaucomatous optic disc cupping and visual field changes. The differential diagnosis of primary open-angle glaucoma with cataract. Patients, it's more for, not for the ophthalmologist, because for the ophthalmologist it's clear, but for the general practitioner, how to differentiate between these age-related types of pathology. Patient with a primary open-angle glaucoma have red reflex during distant direct ophthalmoscopy. In case of cataract, it's a decreased reflex, or in advanced stages, in stage of mature cataract, no reflex at all, no red reflex at all. Ophthalmoscopy reveals glaucomatous changes of the optic nerve disc and no such changes in case of cataract. IOP is raised and visual field defects may be seen. In case of cataract, decreased visual acuity, but usually no visual field changes and normal intraocular pressure. There exists a classification of primary open-angle glaucoma. There exist 4 stages. In first stage, in stage of early glaucoma, there is no changes of optic disc and peripheral visual field. In second stage, in stage of moderate glaucoma, we can see constriction of the visual field borders more than 5 degrees, even in 1 meridian, or maybe in more than 1 meridian. Central and paracentral scotomas. In a third stage of stage of advanced glaucoma, we can see marked constriction of visual field. In 1 or more meridians, we can see that the visual field borders less than 15 degrees from the point of fixation. And we can see severe damage of the optic nerve disc in form of glaucomatous, classic glaucomatous scarring. Final stage of absolute glaucoma, there is no vision, light perception with wrong light projection, or visual acuity is 0, irreversible blindness. Depending upon the level of intraocular pressure, it may be, this classification we use in our country, it's normal from 18 to 25 millimeters of mercury, from 26 to 32 millimeters, moderately raised, and high intraocular pressure, more than 32 millimeters of mercury. And according to the progress of glaucomatous damage, it may be stabilized glaucoma without progression for minimum 6 months or more, and non-stabilized. In case of stabilized, we can continue our treatment, and in case of non-stabilized, of course, we should increase the intensity. Our treatment should be more aggressive. Primary angle closure glaucoma, another type of primary glaucoma in which usually sudden rise in intraocular pressure occurs due to blockage to the aqueous outflow by closure of a narrow angle of the anterior chamber. Another mechanism, trabecula may be normal, but the angle is closed by the root of iris. The peripheral iris tissue covers the trabecular meshwork, preventing access of the aqueous humor to the trabecular meshwork. Predisposing factors are anatomical, eyes in which iris lens diaphragm is placed anteriorly, eyes with narrow angle of the anterior chamber, which may be due to small eyeball, relatively large size of the lens, and anterior position of the ciliary body. First of all, due to the effect of precipitating factors, demyelination, emotional stress, use of mydriatics, there occurs mild dilation of the pupil, which increases the amount of opposition between iris and anteriorly placed lens, with a considerable pressure resulting in a relative pupillary block. The aqueous collects in the posterior chamber and pushes the peripheral iris anteriorly, resulting in a positional angle closure due to iridocorneal contact. Eventually, there occurs rise in intraocular pressure, which is transient to begin with. Clinical features. This type of glaucoma usually begins with acute or subacute attack. Patients complaints of headache and eye ache, blurring of vision, colored gallows around the light due to corneal edema. Frequently, it may be associated with nausea, vomiting, and prostration. Sometimes the pain may irradiate to the heart and stomach area and stimulate gastrointestinal problems or heart attack. So special attention should be paid to the eye complaints in this case. Examination shows congestion. Let's have a look at the patient with the acute attack. Examination shows congestion of conjunctival and ciliary vessels. You see them around the limbus. Cornea becomes edematous, as you see here, and insensitive. Normally, you know, cornea is a very sensitive structure, but in case of acute attack of glaucoma, it will be insensitive. Anterior chamber is very shallow. Angle of anterior chamber is completely closed, as seen on gonioscopy. Iris may be discolored. Pupil is semi-dilated, vertically oval and fixed, no pupillary reaction. You see partially dilated pupil. Optic disc is edematous and hyperemic. IOP is markedly elevated, usually between 40 and 70 millimeters of mercury. I remind you the normal superior border of the normal, statistically normal intraocular pressure is 21 millimeters of mercury. In case of acute attack, it's 40 to 70 millimeters of mercury. So during the palpation, digital tonometry, eye is as solid as stone. Slowly, the positional angle closure is converted into synechial angle closure due to formation of peripheral anterior synechia, adhesion between the iris and cornea. And an attack of rise in intraocular pressure may last long. It was acute attack. Subacute attack is characterized by the same symptoms, but in less degree. IOP is raised about 35-45 millimeters, and subacute attack less dangerous than acute. No, it's clear. Diagnosis. History of the disease, results of examination, and provocative test, but be very careful with the provocative tests, not to start the acute attack and to change it from subacute to acute. Differential diagnosis. Acute attack of primary angle closure glaucoma sometimes needs differentiation from other causes of inflamed red eye. First of all, from the acute iridocyclitis. And here you see the main differential signs between acute attack of glaucoma and acute iridocyclitis, one of the topics which we have discussed before. Onset in case of acute attack sudden, in case of acute iridocyclitis usually gradual. Colored halos, when you look at the source of light, present in case of acute attack of glaucoma and absent in case of acute iridocyclitis. Pain in both cases present, but severe in eye and the entire trigeminal nerve in case of acute attack, and moderate in eyes and along the first division of trigeminal nerve in case of acute iridocyclitis. Vision markedly impaired in case of glaucoma and slightly impaired in case of iridocyclitis. Corneal sensitivity decreased only in case of acute attack. Anterior chamber is shallow in case of acute attack of glaucoma and normal or even deep in case of acute iridocyclitis, and intraocular pressure raised in case of acute attack of glaucoma and usually normal in case of acute iridocyclitis. Several words about the secondary glaucomas. Secondary glaucoma is a group of disorders in which rise of intraocular pressure is associated with some primary ocular or systemic diseases. Therefore, clinical features comprise that of primary disease and that due to effects of raised intraocular pressure. All types of secondary glaucomas may be grouped as follows: uveal or post-inflammatory glaucoma, lens-induced or phacogenic glaucoma, vascular glaucoma, for example, after the post-thrombotic, after the thrombosis of the retinal vein, traumatic, post-traumatic glaucoma, it may be after the contusional or perforative injuries, doesn't matter. Glaucoma associated with intraocular tumors, the so-called neoplastic glaucoma. Uveal post-inflammatory glaucoma is the result of trabecular obstruction by inflammatory cells or exudates as a result of pupillary block due to formation of synechias in the area of the pupil. Synechia means adhesion between the iris, posterior surface of the iris, and anterior surface of the crystalline lens. So adhesion in this area causes the pupillary block and impossibility for the aqueous humor to outflow from the posterior chamber into the anterior chamber. Increased intraocular pressure in the posterior chamber, change of the position of iris lens diaphragm anteriorly, and secondary block of the angle of the anterior chamber. So this is the pathogenetic mechanism of one of the mechanisms of uveal post-inflammatory glaucoma. So diagnosis, history, and examination. The next group of secondary glaucomas, pathogenetic, lens-induced glaucoma. In these cases, IOP is raised secondary to some disorders of the crystalline lens. It includes following subtypes. Phacomorphic, due to ulceration in morphology of the lens, swollen cataractose, anterior subluxation, and dislocation of the lens. And phacolytic glaucoma, as a result of the lens proteins presence in the aqueous humor, and in this type, trabecular meshwork is obstructed by the lens proteins and macrophages. Leakage of the lens proteins occurs through an intact capsule in the stage of hypermature cataract. There are two types of vascular glaucoma, post-thrombotic and phlebihypertensive. Post-thrombotic is a result of central retinal vein occlusion due to formation of neovascular membrane involving the angle of anterior chamber. And phlebihypertensive, it's clear from the name, it's the result of raised pressure in system of veins of the eyeball and orbit. The main causes of this type of glaucoma are malignant exophthalmos, tumors of the orbit, and other causes which are the etiological factors which cause the compression of the veins and increase the pressure in them. Traumatic glaucoma, post-traumatic glaucoma, a secondary glaucoma may complicate perforating or blind injuries. Traumatic glaucoma may develop by one or more of the following mechanisms. Angular recession due to disruption of trabecular meshwork, followed by fibrosis, adherent leucoma, and peripheral anterior synechia formation. Then lens-induced glaucoma due to ruptured, swollen, or dislocated lens. Due to intraocular hemorrhage, inflammatory glaucoma due to iridocyclitis. So in case of traumas, we can see sometimes different types of mechanisms, sometimes even combination of these mechanisms. And in case of traumatic glaucoma, treatment is rather difficult. It may be the result of ocular surgery, like a complication of cataract surgery or transplantation of cornea, like keratoplasty. Finally, neoplastic glaucoma may develop in cases when intraocular tumors block the drainage system. Treatment. There exists a line of management of glaucoma patients. Usually we start with primary medical treatment, or if possible, we use monotherapy. I mean only one drug. If there is no efficacy or partial efficacy of this treatment, we use additional medical medicines. It's better to use them in form of fixed combination. Then additionally, we can use laser treatment, and finally the surgery. In advanced stage, if your primary diagnosis, you put it in advanced stage of glaucoma, we can use primary surgery. It's also possible. What are the main groups of drugs? The most effective group of drug is prostaglandin analogs. They can decrease the intraocular pressure on about 20-25, sometimes even 30% from the baseline. Beta blockers, selective and non-selective. Non-selective are more effective, but they have more side effects. Timolol is the example of these beta blockers. Miotics are drugs which cause meiosis, constriction of the pupil. Pilocarpine is the example, but miotics we use mostly in case of angle closure glaucoma. The mechanism of action is probably exclusively mechanical. So it is used in acute primary angle closure glaucoma to move the iris away from the angle. Additionally, we can use sympathomimetics like brimonidine and carbonic anhydrase inhibitors like brinzolamide, dorzolamide, drugs which cause the decrease of intraocular pressure formation. Prostaglandin analogs cause the increase of outflow. Beta blockers and carbonic anhydrase inhibitors cause the suppression of the aqueous humor production. And sympathomimetics, they have a combined mechanism. But the most relatively effective drugs are prostaglandin analogs. What about the angle closure glaucoma, and what should we do in case of acute attack of primary angle closure glaucoma in case of acute attack, when there exists such severe symptoms as severe pain, very high intraocular pressure, and so on. So we should use pilocarpine, miotic pilocarpine 1%, which should be administered initially 4 times during the first hour, 2 times during the second, and then 1 time each next hour. Beta blockers should be administered to lower the pressure further. Carboanhydrase inhibitors like acetazolamide we can use not only in form of drops but in form of tablets, and here 250-500 milligrams should be given to lower intraocular pressure below 50-60 millimeters of mercury. If there is no effect after 12 hours of medical treatment, surgical or laser operation should be performed, or the changes will become irreversible. What about the surgery? Peripheral iridectomy we use in early cases of primary angle closure glaucoma. Iridectomy means formation of the hole on the periphery of the iris. In case of pupillary block, we create a new pathway for aqueous humor outflow from posterior into the anterior chamber. Then goniotomy and trabeculotomy. In case of congenital glaucoma, we have already discussed, it's a procedure to remove the mesenchymal tissue from the angle of the anterior chamber. Then filtration surgery, trabeculectomy. It's a gold standard for primary open angle glaucoma. We also create a new pathway of aqueous humor outflow under the conjunctiva through the sclera. Additionally, we can widely use the laser procedures on every stage. We can add, we can use laser surgery as a primary treatment. We can use it additionally to the medical treatments. Sometimes we can add it to the post-surgical patients. We can perform laser surgery 7 times because it's rather a safe procedure without side effects. But of course, the efficacy of laser is less than efficacy of the filtration surgery, it's clear. We can compare laser with the medicines, but not with the classic surgery. So that's all. We can talk about glaucoma hours and hours, but during one lecture, it's impossible to discuss all the details. But this is the first step. Then during our practical classes, we'll discuss more thoroughly in details the glaucoma principles of its diagnosis and treatment, because I should say it one more time, it's one of the main causes of the blindness, irreversible blindness in all the world among the adult person. And it's not only medical, but social problem too. Do you have any questions about today's topic, about glaucoma?